Hello, everyone, and welcome to the third webinar in a series highlighting the peer role for those folks with substance use disorder. My name is Nicole O'Donnell. I'm a certified recovery specialist with Penn's Center for Addiction Medicine and Policy. Today's topic, which is near and dear to all of our hearts, is presenting the multiple options or pathways for recovery for folks experiencing opiate use disorder. I'm going to hand it over. I cannot do justice in introducing our panel, so I'm going to hand it over to Brooke to get started, and she can introduce herself.
Of course, it's the one taking a sip of the water.
Sorry, Brooke.
Hi, my name is Brooke Feldman. I'm a person who overcame a substance use disorder, have worked in settings where there is access to the medications used to treat opioid use disorder, and I am happy to be here.
Andre?
Hi, I'm Andre Reed. I'm president of Philadelphia NAMA. President of Philadelphia NAMA. I'm a person who walked through the process of recovery, started lived experience consultants in 2019 to deal with the disparities in the pathways for people who utilize medically assisted treatment and who suffer from opioid use disorder.
Thanks, Andre. Paul?
Hi, my name is Paul Bowman. I'm a person in long-term recovery who's on medication for an opiate use disorder. I was on methadone, now I'm on buprenorphine, and I'm coming to you guys from Boston, and I was a former recovery coach at Mass General Hospital for the past 2 years in the emergency department, and now I'm in a community health center, the South End Community Health Center in Boston, doing community health in an OBOT, like a Suboxone program, buprenorphine program.
Thanks, Paul. And Dave?
Hi, good afternoon, everybody. My name is David Malloy. I'm an individual in long-term recovery. I'm also a mobile service director for Marquee Parkside Recovery. I just want to, being that I'm a kind of one of them two-hat kind of guys, somebody in recovery that works in this field, that hopefully can shed some light on like my evolution over time, how I've begun to realize that there's a lot of different ways to do this. That's it.
Thank you.
Thanks, Steve. And Dr. Maggie Lowenstein.
Hi, I'm Maggie Lowenstein. I'm a primary care and addiction medicine physician, so I provide treatment with medications for opioid use disorder, and I'm lucky enough to work with Nicole and other people in recovery as peers who make my job a lot easier.
And Dr. Maggie is going to present some of the evidence behind some of the treatment options.
All right, thank you, Nicole. So just to get us started, Nicole asked me to present a really brief overview of medications for opioid use disorder, or MOUDs, you'll see abbreviated. I think this is probably familiar to most of you, but hopefully it will help frame the conversation that the panelists are gonna have moving forward. So really basic, there are 3 FDA-approved medications for opioid use disorder. These include methadone, buprenorphine, and extended release naltrexone, which is the brand name Vivitrol. And they all work slightly differently, but the goal for all of these medications is really to help stabilize patients and break the cycle of chaotic use or other things that really define a substance use disorder. And so medications for OUD stabilize patients by preventing withdrawal in the case of buprenorphine and methadone, which are either full or partial opioid agonists. They also, all 3 can reduce cravings, and that really helps kind of decrease negative reinforcement that might drive return to use. And then also, in the case of methadone and buprenorphine, they reduce the risk if a patient does, in fact, return to use. And in stabilizing patients in this way, medications really provide opportunities to address all the other components of a substance use disorder, so the social, behavioral, psychological, et cetera. And so they can provide, they really allow patients to engage in all these elements that are important for recovery. So really important to note that without medications, we know return to use of opioids is really high. What you see here in this picture is from an older study where they looked at patients who'd undergone a detox and then were discharged off of medication. And the researchers looked at outcomes over time and for the first 30 days after release. And what you can see here is that in the days following a detox without medication treatment, the return to use increases pretty quickly. And by the end of 30 days, it's only about 20% or so of patients have not returned to use. So 80% of patients at least have returned. And then from other studies where they look out even longer, we know that the rates of continued abstinence are even lower. And so by a year. So just to summarize, overwhelmingly, the evidence shows that non-medication treatment isn't really very effective for most patients. I think to add to that, the other issue that we're facing is that if patients don't use medications, the risks are really high if they do return to use. So we know that any period of abstinence, whether it be from hospitalization, an incarceration, or like an inpatient detox, rehab, or outpatient treatment without medications, any of those periods of abstinence result in a loss of tolerance, and that happens within a matter of days. And then if someone loses their tolerance, the risk of overdose, should they return to use, is really high. And of course, in our current climate, where we know that we have this potent and unpredictable drug supply, particularly with fentanyl, the overdose risk is even further amplified. So just to kind of summarize, my punchline here is that without medications, we know that patients are more likely to return to use, and also they're at high risk should they return to using. Of course, the good news we all know is that medications for opioid use disorder are really effective. So opioid agonist therapy, in particular, methadone and buprenorphine, reduced risk of death from overdose or other causes by about half. And they also improve many other outcomes, some of which I have summarized in this chart. So just all three medications for OUD lead to improved retention in treatment and reduced ongoing opioid use. And then in the case of buprenorphine and methadone, as I already mentioned, they reduce the risk of overdose death and all causes of death, whether that be infections or other accidents, other things. They also reduce HIV risk behavior, and we know other kind of risky substance use behaviors. And then I think really importantly, and in a patient-centered way, they also improve quality of life. So all kind of a variety of really important and meaningful outcomes. And finally, we know that treatment with medications for OUD is more likely to stick. So this slide shows data that's combined from a few different research studies and looks at treatment retention and reduced illicit drug use at 12 months. And what you can see, behavioral therapy without medications, the retention is really low, 6% in this study, but that's very low. It's higher with medications. Again, you can see slightly higher with extended release naltrexone and much higher with buprenorphine and methadone. And so this is really important because it means that patients are more likely to remain engaged and be able to do all the things that they need to do to support recovery. So now that we have some data to frame the conversation, how can we help patients to make these treatment decisions? I think first and foremost, it's really important to say that, of course, patients are always free to decide, and we want to empower patients to understand and make decisions about their treatment. I think part of respecting patients and the decision-making process is to really provide patients or their families or both all the most accurate information so that they can make a fully informed decision. So as a PCP or primary care doctor, I do this all the time, whether it's for diabetes or heart disease, cancer, or a substance use disorder. I want my patients to know what the treatment options are and what's most likely to keep them alive and healthy. And so in my own practice treating patients with substance use disorders, I've found that peers play a really, really important role in communicating this evidence. I can tell people about all the data until I am blue in the face, but it doesn't really matter to a patient if they feel like they won't be supported or accepted in their community if they make the wrong choice. And so I have found that working with peer recovery specialists, certified recovery specialists, whatever they're called where you are, is really important in bridging that divide between the kind of medical provider and the patient community. And so with that, I'm going to turn it back over to Nicole to start the conversation and guide us through today.
Thank you, Maggie. We are going to start off with a personal story, dovetailing and highlighting all of the evidence that Maggie just presented. So I was, as part of my job, we do outreach in the community. So I met this person, his name is James, in McPherson Square doing outreach. I was with a fantastic medical student that day, which is just an amazing, like, our medical students and residents want to be advocates and they want to learn. So a lot of times they'll ask to come out in the community to do outreach with us. And I happened to have one student with me that day, and we were handing out Narcan and snacks and fentanyl test strips. but most importantly, we were having compassionate conversations with people. So, and when you do outreach for a long time, you eventually have an instinct when someone is experiencing like an extra hardship, they're extra distraught, right? And that was James. He had been reversed from an overdose about 20 minutes prior to our meeting him. We sat and we chatted, ensuring that he did not experience re-overdosing, because we know that Narcan is short acting and opiates still remain a threat once the Narcan wears off. We found out that James had been released from a county jail 4 days prior to our meeting. And this particular county jail uses buprenorphine for withdrawal management, but not for continuous care. James identified that the medication is a goal for his recovery, but he was released without resources, support, or insurance, so that really seemed unattainable. And I am afforded such privilege to have compassionate providers, just like Dr. Maggie, on like speed dial. But like Brooke always says, you shouldn't have to know somebody to get help, right? So I did have to utilize my resources that day, and James left McPherson Square. We went to Penn Presbyterian to ensure that his pathway of recovery came to fruition. In about an hour, James left the emergency department with his prescription of buprenorphine and transportation back to his respective county, and he had peer support. Had James had the opportunity to follow his pathway, we may have not had to meet him in McPherson Square right after an overdose. And today, the panel will discuss the importance of educating and supporting folks about their journey to wellness as defined by them. So I'm going to hand it over to Brooke, and she is going to present us what the Riddle Scale means.
Thanks, Nicole. And yeah, I love that you start off there, right? Because there is a real human impact to people not having access to these medications, or not being, informed, educated, and, the direct consequence for some can be a preventable overdose, and sadly, the worst outcome is death. So it's a good place to start. And when we were preparing for this webinar, I was sharing that, number one, it's important to begin from the place of I did not pop out of the womb as somebody who was embracing and affirming of the medications used to treat opioid use disorder. I kind of grew up in treatments in the youth serving and then the adult serving treatment system. I was in my first 12-step meeting at the age of 13. So I really kind of grew up and was indoctrinated and sort of socialized in certain ways about addiction, about recovery, about what counts as recovery, what doesn't count as recovery. And in the very spaces that I often was in seeking help for my own substance use disorder, I heard messages like people who use what we, used to call, medication-assisted treatment, or MAT. People who use MAT, are taking the easy way. They're not really in recovery. That if I can do it without medication, they can too. And all kinds of really harmful things. And for me, it was a process of unlearning. So I share that just to normalize that, there's a lot of messaging that many of us have received regarding the use of medications and regarding this notion of what counts as quote unquote clean and not clean. And so this scale that you see in front of you is something I've used in having the conversation before. It's typically, the Riddle Scale is typically used to look at sort of, the scale between repulsion and nurturing the LGBTQ plus population, but it really does fit when we have this conversation. And so you see on the left of the red square is kind of one end of the scale is repulsion. And I've seen this when it comes to people using the medications to treat opioid use disorder. And then after that, you get into pity, and then tolerance. And tolerance is sort of okay, if you need to use that medication, in order to get through the detox process, but it gets you to a place of not using medications, then I can deal with that. The same thing with acceptance. And I always highlight that, as a person, who has been in many, treatment and recovery support spaces, I remember learning that acceptance was the place to aim for. If I accept something, then that's I've arrived at where I'm supposed to be. But acceptance does not feel like what you see in those green boxes. And I use my own experience as a queer person, right? When someone's I accept that you're gay, and they think that feels good for me, that doesn't feel good, right? It's kind of like you maybe don't like it or agree with it, but like you accept it. And so what we really want to strive for is what we see in the green boxes when it comes to people who are utilizing an evidence-based, like that we know this cuts the risk of overdose death in half. The Dr. Maggie just went through this. We really want to be, aiming to provide support and like admiring that somebody's taken this journey that many of us know is a really difficult journey to take, no matter what pathway you choose. And then you see appreciation, and then nurturance, and that's kind of the vision, right? Like where we want to be is to have nurturing spaces for people, regardless of what pathway they choose as the best one for their own recovery, whether it's total abstinence, whether it's moderation, whether it's the use of medications or not the use of medications, that we want to have nurturing spaces. And the last thing I'll say is, what made me think of this scale some years ago is I remember, early on in my own journey from recovery from a substance use disorder, I would go to this meeting, 12-step meeting, and there was a guy who was utilizing methadone at the time. And he was like treated like a second-class citizen, like it was almost like people were afraid to sit next to him. Like they would catch the methadone, and wasn't allowed the same privileges as other members of the group, wasn't allowed to have service commitments, and was very much treated like other than and different. And I remember one night, and I was young, I was like 25 at the time, which I guess, I'm getting old. I just turned 40, which is scary. But I remember he just like raised his hand one night to share and basically told the whole group about themselves. Was like, you make me feel like crap when I come here. You make me feel like I'm not a part of. I'm here to, save my own life and recover just like the rest of you. And I remember just like really feeling his message and thinking that as a collective group of people that were, there to support one another in their recovery, that, we really failed to do that for this guy. And sadly, a couple months later, I learned that he had died from an overdose death. And for me, it was really one of those transformational moments of, had our space been what you see in those green boxes, had it been supportive, had there been an admiration that he, just like the rest of us, was there working to save his own life and to find wellness and recovery, had we really had a nurturing environment, then that's a life that, was lost that didn't have to be and could have had a different outcome. So hopefully that's helpful as far as like the framework. And also the last thing I'll say is, just to normalize that, again, just like I didn't pop out of the womb, understanding this stuff, and just like I had to unlearn some harmful messages that I picked up along the way, you may not be all the way, in that far and right nurturing spot. And it's important to kind of be honest with ourselves, like, where am I? Like, do I really embrace these medications, or is it that I just accept them? And wherever you're at, it's okay. But the goal is that we move further along with each day and each opportunity we have.
Thank you, Brooke.
Thank you, Brooke.
That was amazing. Dave, can you talk about your evolution with medication and as being a member of the 12-step rooms? You're on mute. Somebody had to do it. It's fine.
Of course it was me. I was just muting it because I'm in an office. I didn't want you to hear all the craziness going on in the back. In any event, I'm an individual in long-term recovery. When I started in this field in 2006, I had about a year and 3 months, a little shy of 2 years. And I was doing my interview, and the company I was interviewing at has many programs. A lot of their major big programs were large methadone clinics. So that came up in conversation, and I ended up having an argument with the director because, like, at the time, I just had this kind of deeply embedded thing that, like, and you hear it a lot, and I don't, I hope I don't come off as, wagging my finger at anybody, but, if people just need to do what I do and they'll get, the same experience that I have, that was kind of like my thought process. And, that was how I went into this. I was still given a job. She actually called me 3 days later and said, hey, I want somebody on my team that's passionate, and even though we disagree, I can get down with your passion. And they hired me. And I still work for that company today. But God has a sense of humor because about 11 years later, I ended up being the intake director for probably the largest methadone clinic in the city. In those 11 years, I think a lot of it for me had to do with I got tired of going to funerals. I got tired of watching, and I just kind of evolved in my own recovery to, I don't know, like reduce the edges of narcissism that come with early recovery, that come with like realizing the potential that I have as a person. I began to just kind of see things in a broader picture. But another piece of that was I got to really know people on an intimate level that were on medication. I worked at a program in Frankfurt, and we were one of the first programs in the city that started using buprenorphine, and we started transitioning folks from methadone onto Suboxone. So these individuals that I was meeting were folks that were in long-term recovery. One of them is actually a panelist with me today, Andre. These are individuals that are in long-term recovery. And guys, if I'm fully honest with you, which, sometimes I'm honest to a fault, back then I would spend an hour with these guys or a half an hour, and we'd have a very intimate, deep conversation about life, recovery, what that looks like, emotions. And those guys would leave, and they're all on medication. And I'd be sitting at my desk thinking to myself, this freaking guy's doing better than I am. And it really started to help me reframe the discussion and the idea of what recovery looks like. Now listen, the reality for me in my life is, and I do a lot of outreach like Nicole, the reality for me is there's people that I deal with on Kensington Avenue on a daily basis that I would trust more than some people that I know that have 20 years in quote unquote recovery. Because I think somewhere along the line we got into this kind of idea that recovery is the absence of substances. But I know some people that live purer lives and are homeless shooting heroin on the street right now than some folks that I know that are seen as like recovery gurus. So there's been an evolution. I've just realized I think fentanyl has played a key role in that. I think that's why it's so important for folks like us and people that are getting into this field to really have these kind of difficult conversations. I think a goal of mine is, if there's any new CRSs on this call that have those deeply held, my goal for this webinar is that I want to disturb you about that. I want you to be thinking about what we're talking about today, later tonight when you're laying in bed. Because we can play a very critical role in somebody else's recovery. Look, the truth of my experience is that my recovery actually began with somebody else's motivation, somebody else that was willing to kind of share themselves with me. That's my truth. So we have the ability to do that, but when we're going to somebody, and Nicole eloquently highlighted that in James's story, when we're not presenting people with those options, not to go on a tangent, but I feel I'm coming on, so you're taking the ride with me, people. Our system for a lot of years poo-pooed medication. Like, people would be in a rehab, they'd be on medication, and then all of a sudden, 4 days before they're getting released, they're like, oh, we can't get this guy a bed in the recovery house because the recovery house won't take him on medication. And I don't have concrete numbers, but I guarantee you that some of those folks that were reviewed in those death reviews, I guarantee you, if you look back at their history, they were recently in detox, they were recently in jail, they were recently removed from these substances, where we had a chance to put this intervention in place, and because of some systemic challenges, we weren't able to do that. That to me is the goal of webinars like this, is creating a group of people that can go out and not be jerk-offs about it, and not, but like be passionate enough to get people to understand that, like, listen, man, you can do any one of these. Just get, pick one, find the one that's most suitable. The cool part for us is we have doctors like Dr. Maggie that's on this call today, and a ton of other ones across the city, because that's been refreshing. There's a lot more progressive thinking doctors floating around these days that can help people identify, Chief, this is why methadone might be a better fit for you. Or this is why Suboxone might be a better fit. Or this is why naltrexone might be a better fit. But we're able to kind of put all these things together to make that difference. So sorry for my tangent.
No, that was good, Dave. And somebody had to curse first. So thank you. Thanks for doing that. Andre, can you tell us about the meetings that you hold for people that are on medication?
Hi, everyone. First of all, thank you, Dave. Thank you, Brooke, and everyone who went before me. First of all, I think lived experience is a very important component of the subject that we're talking about, right? I think it's very important that when people understand the pathways and the process that happens along this way, then you'll start seeing how the obstacles come, but then how do we work around the obstacles? How do we find other processes and recovery supports that can help a person get to the places? Because sometimes we're not looking at, I don't look at the pathway, I look at the journey, right? So we're not taking the route. We don't pay attention to the route. We start paying attention to the route, then that's where the stigmas and the disparities come in, because we're looking at how a person gets to their process of recovery. It's really not none of my business how a person gets to a process of recovery. But what I do need to do is educate them. So when I do trainings for SAMHSA, OR, and Opioid Response Network. And when I do go into the trainings with laymen or people who are already experiencing, the first thing I do is educate them on why this person has made this decision. Coming from a person who don't understand addiction, the first thing you think that this person has made the worst decision in the world to get on methadone, Suboxone, or Vivitrol, right? So you're saying, what will make somebody get on that decision? But then you have to start flipping and make the people realize that for that person, that's hope. That decision to go into medically assisted treatment was not made from a position of trying to get high, trying to find replacement, trying to keep their lives in this perpetual cycle of hell. No, that decision was made out of hope. That if I get on this medication, that maybe I probably could get my life together and things to start working for me, because up until this point, I've tried everything I can and I can't get there. We understand that, right? So statistics show us that somebody who uses opioid use disorder, brain has been changed, and the process of trying to get themselves free of drugs by themselves is probably a 20-year process, probably none or never, right? So we see the statistics, Dr. Mackey, so we see the statistic that somebody who comes out of treatment without medically assisted treatment will use right away. Somebody who does come out of treatment with medically assisted treatment, detox I'm talking about, or rehab with medically assisted treatment, go 90 days and we see them go longer, right? So how do I bring process of hope to the people? By educating them on what the medication really is about. So let me tell you with disparities, the medication doesn't destroy your bones. It doesn't take your teeth out your mouth. People who utilize medical assisted treatment properly can go to work and they won't crash their cars. I mean, they do have good jobs and they are productive members of society, right? So now I need you to stop looking at what medication they're on and look at their process and their route and look at the benefits of the medication and not what medication is. So a lot of times people look at the medication and not the benefits of the medication. January 2001, I was at Parkside. Now you got to, and I'm gonna say this in closing, you got to understand where Parkside was back then. Parkside was called the zoo. There wasn't no treatment, wasn't no recovery coming out of there. So for me to come out of that place and gone on to do things I've done with my life, was a personal testament to what not the program itself, but the program helped, right? But what the program and component with the medication can do with proper people and proper supports around you, where it can take your life at. So that's what I teach in my trainings. First, I'm going to educate you on what this medication is, right? I'm going to educate you on the lies that the streets have said about this medication, that it is replacement therapy, destroys your bones, and knocks your teeth out. That's all a lie, right? I'm also going to show you that it's the gold standard for opiate use disorder. We know that already, right? Highly tested, highly researched, highly tested medication. So it's one of the most tested medication there is, and research medication of all the medications on the market. And then I'm going to introduce you to people who have been successful along this path, whose lives have came back together, who have good productive lives, and understand that it's part of a process. It's a journey. So it doesn't just start right away, but if we can get people on a proper path, we can get them in the proper support with the proper people around them that's helping to guide them, then we can start seeing positive outcomes. And I really think that lived experience is one of the major components to it, because what lived experience does is it helps the person, we talk about the black and the white, but then it fills in the gray. I know what it feels like to go home, because I'm gonna tell you this: most of the time, it's not the people in medically assisted treatment program that want to get off of there; it's the people around them. So when you go home on a medically assisted treatment program, your girlfriend is telling you, why did you make that decision? Your mother is telling you, why did you make that decision? Your friends are telling you why you make that decision. So now you're confounded by people with non-medical advice giving you medical decisions. And you're making your decision based on non-medical professionals who know nothing about what decision you have made. So I got to get that person to trust themselves. I need you to trust the decision you made, not the people around you that's telling you you made a bad decision, because they don't know the hell you called to make that decision. And only when you start having positive reinforcements from this decision where they start believing and trusting the decision you made. But if you continue to go along the path that's negative, then they're going to see your decision as being just as bad as being on the heroin. So now we gotta drown those people out, right? Mom, I gotta go to this program because it helps my life. Look, girlfriend, I gotta go to this program because it helps my life. You're not the one stuck in the alley putting a needle in your arm. You're not the one living under a car putting a needle in your arm. So when I make this decision is based specifically on my life. And I want you to be with me, but if you can't be with me, then I'll find other supports around me that can support my decision. So that's one of the major components that I talk to people about in the training, is that making decisions on medically assisted treatment will be a decision that's going to get a lot of backlash. But you need to trust your own decision, because the benefits will come if you trust your decision and let the medication work. Thanks for allowing me to share.
Andre, your passion's so inspiring. Thank you.
You're welcome.
Paul, can you talk about the conversations you have bedside, or you did have bedside in the hospital with patients experiencing ramifications from opioid use disorder?
Absolutely, but I'm going to first tag on to Andre and say this medication that I'm on buprenorphine, that we shouldn't have had to die before we get access to it, right? And when I went on to methadone in 2000, I had to have 3 failing attempts, positive urine, blah, 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 blah. What other medication? I mean, things are easier now. You don't have to have all these failures at other treatment forms. It would be almost like you'd have to have a heart attack to get a Tylenol. Now, would that make sense to anybody? Of course not. You should be able to be treated for high blood pressure as soon as you have it, so you don't have to have a heart attack. But people literally have to die, and this is kind of tags to your question, Nicole. They overdose, and they come into the Massachusetts General Hospital, 136-bay unit, right? Emergency department. And if they're lucky, like Brooke said, and hit the lottery, and I'm there that day, I work 8 hours a day, it's a 3-shift place, there's an addiction consult unit. And if the nurse and the attending and the NP and the PA refer this person to see us, sometimes they won't. I can't just go fishing for overdoses in the ED. And but hopefully they'll do that. So this conversations bedside are often, they're ready to do something different. And the good outcome would be what you had with the person on the street. They're leaving with buprenorphine prescription, or actually 4-day supply. But the warm handoff, we're lucky enough that we have a bridge clinic, so I can walk them up to the bridge clinic, introduce them to the doc and all that. But unfortunately, there's too many times that I'm not there, and that one of their friends comes in, or maybe this could even happen too. A recovery coach that didn't believe in buprenorphine or Suboxone and say, "Mate, you really want to go into liquid handcuffs? Do you want to do that? And maybe you should try to go, back to the wherever they went to, or treatment." And that's the scariest thing, is when you don't have people that support you. But mostly, we don't have that. But we did have a problem with that originally. But I think the problem is that you have people that support medication-assisted treatment, and peer recovery coaches. So many of us, or not me, but a lot, are on medication, but they're afraid to be out about that. So that to even say, "Hey, I'm a recovery coach on Suboxone or on methadone," and believe me, half of the staff that I work with are on medication, and I'd say only 20% help people about it or share their experience, because they're afraid that it's going to be used against them at some point. That's how crazy it is out there. I remember trying to get a job in a methadone clinic, and they said to me, "We'd never hire you if you were on methadone at the clinic." And that was a long time ago. but things have changed. I don't know how much they've changed, but being a person on buprenorphine, I plan on probably being on this forever. Many years I tried to go without methadone, and I went from detox to detox to detox to detox to going to front of a judge, and then I got methadone, and then I got an apartment, I got my dog, I got my life, I got meaningful relationships. All these things came, but nobody even wanted to give me access to methadone because they say, do you really want to go into liquid handcuffs? For God's sake, I'm living on the street. Of course I want to try anything that'll work. What kills me the most or upsets me the most is I'll meet a mom or something that'll say, it's so great to meet you. You're so to meet somebody in recovery with your passion and their thing, and they'll say, I lost my child, and we never even knew about buprenorphine or methadone or Vivitrol. Nobody even told them. They went to 15 different 30-day programs, and nobody told them there was a medicine that was science-based and evidence-based. So that I probably used up all my time, but thank you.
No, that's great, Paul. And I can relate to that a lot from being in the hospital, and we hear a lot of stigma from the patients. And I'm going to ask Brooke next to talk about her experience training new CRSs and how we, the evolution with the conversations that we would have with them and how you train them to do that.
Yeah, as Paul was talking, I'm still overheated from Andre bringing the fire. I just need to acknowledge that.
Yeah.
But as I was listening to Paul, I remember, this was within the past 5 or 6 years. I was, coordinating the CRS training program, and it was geared towards CRSs who wanted to work with young people. And it had it was HRSA funded, and there was a scholarship. And so we had an interview process to make sure the person was engaged and committed to the whole program. And I remember there was one person who just was I was blown away in the interview. This woman is going to have a positive impact on any human being in any agency she touches, type of blown away. And at the end of the interview, very quietly, as if it was this shameful secret that she had to share, she's I'm afraid to tell you this, but I feel that I need to, her words, I'm on methadone. Is that going to disqualify me from the training? And I feel because the work and education that I've done around this, that I'm a pretty safe space, right? That I think someone could be around me and see that I'm not going to be judgmental of their pathway to recovery. And even in that space, just the shame that she felt and the idea that this would make her not a good CRS was heartbreaking. And obviously, the conversation then just went into, absolutely, you're going to make an amazing CRS. And in fact, we need more CRSs who have experience using these medications. My personal pathway, finding recovery from an opioid use disorder did not involve the use of medications, but only because it wasn't offered to me. And I have to say that because of how indoctrinated I was in the stigma surrounding the use of medications, I don't know if I would have said yes or no. Because has been mentioned by our panelists, what we see is that stigma gets internalized, and then it also can become shame, right? And so people often will choose not to use these medications because of the things that they've been taught. But what I think when it comes to peer staff, so it's, having lived experience with any kind of condition, whether it was cancer, whether it was diabetes, whether it was adoption. I'm a step parent. I'm looking for my step parent support group if anyone knows of one. If you have lived experience, your ability to connect with somebody is just, unique in a certain way. It's not better than, worse than other roles. It's just very unique. But it can be a disadvantage if we don't do the work, right? Because the reality is that my lived experience, what worked for me to no longer have a substance use disorder, is going to work for maybe some other people. But for most people, that's not what's going to work. And so it's how do we really kind of, sort of harness the gifts of those of us with lived experience and the ability to connect, but not bring the disadvantages, which is that if I did it this way, then you should be able to too. And the last thing I'll say is I think when it comes to training and education, sometimes we not only don't know what we don't know, but we also don't know if what we've been told is wrong, right? Until we have a chance to kind of be challenged about that. And so I think it's really important. It's a huge honor and privilege to be in service to others, but we have a responsibility to really make sure that we're not doing any harm and that we're educated and informed beyond our own limited experience, and that with equity, we support any pathway to recovery. And that is not just a talking point or something you check off on the CRS test, that we truly live that and people can feel it. Because this is the last thing I'll say for real, like people can feel it, right? Like you can feel if someone truly like is supporting your choices and like what you're doing, or if they are accepting it and like don't really agree. And I know for me, I usually don't go back to that person, right? If I felt judged for my choice, like I'm not messing with you again. Like I'll go to somebody else. And so it's really important that the CRS does not become another one of those kinds of folks.
Perfect. Thanks, Brooke. You don't forget you can utilize the chat for questions, but we'll keep going. I'll keep an eye on it. Dave, how do you talk through the stigma when you meet somebody, a person who's experiencing opiate use disorder? How do you talk through the stigma, like I'm not clean unless if I'm taking medication, I'm trading one addiction for another? Andre, too, I'd really like to have his input here.
Yep. And so I would just say this, like a lot of those conversations, a lot of them have happened with families, but a lot of with individuals, you know, because they'll pull me to the side because I'm very transparent about my own recovery. So they'll be like, you know, and the sad truth is I have to keep numbers of people that are in the rooms of recovery that I know are friendly to these kind of folks so I can point people in the right. And I don't know if this is going to make sense to everybody, but it really is like a slow process where you talk somebody through that, like to understand, like, listen, people are going to judge you. It's the reality. And there's a certain thing that you can tap into because you kind of get them to buy into the idea that like you're part of this thing and we're slowly but surely changing things. I often feel like a priest, and I'll explain why in a second, because I know there are people in the rooms of recovery that sponsor people, that speak all over the place, circuit speakers, the whole bit. Nobody knows they're on medication. I know they are. Nobody else does. So I have that little bit of information that I can share with folks to be able to say, like, listen, especially over these last several years as the fentanyl has become such a major issue, this is what, you know, this is what we're dealing with. You know, so when somebody comes in and they say, like, hey, I'm active, you know, I'm in this recovery house that makes me go to these meetings. I kind of like have a quick little sit down with them and explain, like, look, this is what you're going to deal with. There's going to be some pushback. You're going to run into people that, you know, are going to have something to say. But ultimately, you know, this is about you. It's about your recovery, and I can point you in this direction. I think it is sad that I have to have that list of contacts of people that like I can point them to that will guide them in the right direction, that won't make them feel ashamed, that won't treat them the way Brooke was talking earlier about that gentleman. But I think, you know, when you think about it, and then I'll shut up, I promise, it seems like it's almost like everybody in recovery, everyone takes a different way to get up the mountain. You know, there's people that take the Christian way up the mountain and they get there. There's people that take the 12-step way up the mountain and they get there. There's people that take the therapy and psychiatric route up the mountain and they get there. And the goal of all these different things is to get to the top of the mountain and enjoy the view. But people in recovery, instead of getting to the top of the mountain and enjoying the view, they want to turn around and argue with the next person in line about how they got up the mountain. And I think that goes back to what Andre was saying earlier about everybody. We need to be able to educate people on all the different ways that people can get into recovery, all the different ways that they, and the reality is there is no one way that's better than the other. These are all different ways to get there. Frankly, I think medication is much more indicated in the population that I'm working in. I won't speak for anybody else but myself, just because we're primarily in Kensington. But if I run into somebody down there that adamantly says I don't want to be on medication, all right, let's bop to your drop. Let's find something else that's going to work. Let's try to get you connected to this program, because they're all different pathways. So I'll shut up.
So,
Thank you, Dave.
Andre,
I'm afraid you're going to burn the house down if you get started again. But how do you talk through stigma?
I'm not going to go long. All I want to say is this. I talk to people about life skills, right? And when I talk to them about life skills, we start teaching people in recovery boundaries. And what the first boundary is, nobody goes around and tell people what medication they're on, so why should you? Nobody goes around and tell you they're on HIV medication and you're on psych meds. So when you walk into a Narcotics Anonymous meeting, your medication with your doctor is your private information. You're only there to deal with substance use disorder or disease of addiction. So why you get on the bus and tell people you're on medical assisted treatment? Why you walk into your job and tell people you're on medication? Nobody walks into the world and tell people what kind of medication they use to stay healthy, right? So we look at the world. We living in a medicated dependent world, right? We use medication dependency. So we talk about addiction and dependency. We use dependency for medications for everything right now, right? A man can stay young off of medication. That's a joke. But we can use medications for everything, right? Mental health disorders, heart disease, whatever. And now we're starting to use smart medications. Kevin Howard says this all the time. We start using medications to deal with opioid use disorder. More fortunate today, right? Addicts are more fortunate today. Maybe I looked at the Billie Holiday story. Maybe somebody would have told Billie Holiday early in her process, or Kurt Cobain early in his process, hey, you can use this medication, it can save your life. But it's more fortunate today. But my people, I say, that I train, I talk to them, don't go tell nobody what medication you want. When you walk into a Narcotics Anonymous meeting, it's not their business. You're there to deal with the disease of addiction and the characters and the behavior that cause you to destroy your family, your life, and the people around you. How you get there is nobody else's business. You just need to get there, right? So if you're using medications to get there, then that's between you and your doctor. So even I'm going back to everything I've been trained. Follow HIPAA. HIPAA says nobody can't know your medication. You don't need to walk to the world and tell the world you're on medication. Nobody else does. So why should people with medical assisted treatment be thinking that they need to? So when they walk out of Parkside and they go into the world, Parkside can stay at Parkside. What people are going to focus on is your process, your behavior. And what type of person that you wind up showing up being. Now, when you sit on one-on-one with Dave, you sit on one-on-one with me, you sit on one-on-one with you or Brooke or somebody, then you can say, hey, I'm dealing with that. But as far as society as a whole, when I'm training people, I teach them about life skills. Don't be on the bus, hollering across the bus, hey, I'm on 40 milligrams. Everybody you talk to, you tell them how many milligrams you on, or that's not nobody's business. But how would I know that? I went through that population, right? So I remember being on buses and I would hear people talk freely in front of everybody about their medication and on Suboxone and stuff like that. That's nobody's business. It's between you and your doctor. What people will look at is your journey and the results of what that medication is doing for you. So again, I go back to focusing on the results and what are you using the medication for? Now let's help the medication help you succeed your goal.
No, that's great. I use the Catholic Church as an example in birth control, that the Catholic Church doesn't believe in birth control, right? But all the women that go to church on Sundays that are on birth control, don't go telling the priest that they're on birth control. But I also like to change the stigma in general, and people are able to not feel stigmatized while they're on medication and be able to talk about it if they choose to too. There's a really great question in the chat about Suboxone. There's the argument that it can be abused. How do you address that? If you have someone who is abusing it, what do you tell them? Oh, it's moving. What do you tell them when they have said now is not the right time and they want to stop?
I don't think people are going on the street corner looking for buprenorphine to take, right? If I was there, I would be getting some fentanyl. If you're going to get high, you're certainly not going to choose buprenorphine. It's not a very good high, number one, right? When you're naive, it's very. I've abused buprenorphine, so I can answer this one. I've injected buprenorphine. I've injected Suboxone. It's injectable. There's no safety to it. That's a bunch of crap. That Suboxone, any different, some Subutex. So that was all misled by Reckitt Benckiser in Indivior. So people can shoot up those film if they want to, but unfortunately, the high blows. So people just aren't going to do that. But if people don't want to be, what was the second part of the question, Nicole?
It says something about stopping. So I think it's more about diverting. So Maggie and I, we talk about this all the time about diverted meds. So if Maggie, you want to talk about how you deal with it in your clinic too after Paul, that would be helpful.
We call it sharing in Massachusetts. So sure. We share her meds because many people can't afford to be on Suboxone. Not that this is the right thing to do, but I know people that got, I never use the word clean or dirty, recovery because of shared meds or diverted meds, more meds that unfortunately people are able to, not be sick getting some medication. And so many people, probably half of them that I know, started buprenorphine, Suboxone with shared meds or one from
Yeah,
their
no,
friends.
I did. Yeah. That was my experience with it. That's why I'm in recovery today, because of diverted medication.
Yeah, I mean, I would echo everything that's been said in my experience with patients. I still, even to this day in Philadelphia, which I think has relatively good access to treatment relative to many places, there are a lot of patients who start and or maintain themselves on non-prescribed buprenorphine. And I like to call it non-prescribed or shared because I think diverted sort of does bring about the stigma. I think to me as a provider, I obviously don't prescribe with the goal of like somebody else getting it. If I learn about that, I say, hey, let's bring them in. But I think from a kind of like societal thing level, the fact that there's any market for it suggests that there's just not enough access. And so I think that's often used as an argument to say like, oh, we need to really restrict the access to buprenorphine. We need to keep people on the lowest dose possible. And to me, it's really the opposite. It's that we don't have access to it, that people want it and need it. I see a lot of heads nodding from my co-panelists. So, I think Paul, what you shared is really valuable too. And Nicole, that you both sort of experienced this in real life. And I think this question about when it's time to stop, I mean, I don't know if that's also related to like the timing of treatment. And I think, I would echo what Paul said about his own experience. I don't see there's any reason for most people to go off of it. We know that it's effective long term. I think Andre brought up there's a lot of misnomers about like the side effects or the this or the that. And it's really like, we know, I think in my practice, I usually treat it sort of like somebody like an antidepressant, where like for many people, it is the best option to stay on it long term. And there's really, it should never be the goal to sort of plan to get off of it. Like that doesn't have to be and shouldn't be the goal. So I think I'll stop, but I appreciate the question because this is something that comes up all the time. And you can see, I think we're all very passionate about like, this is a misunderstanding, but I think it's really important that we have these discussions because you hear that all the time.
That was
I
from
just
the
wanted to
old
give
man.
a plug for Sub Blockade. I get a bunch of people that I see that try to weekend warrior. They're young guys or whatever, young women, and they don't take their buprenorphine on weekends, and they may use heroin on weekends or fentanyl. And they were smart enough to say, can I get the long-acting injection shot for the monthly shot? And they have been able to use that in order to deal with weekend issues with buprenorphine. You have to stop probably Suboxone for 4 or 5 days in order to get the effect of a normal opioid. So it's been really helpful to have the long-acting Sublocade shot. And I'll shut up now.
Thanks,
We
Paul.
just gotta realize we're in a new phase of medically assisted treatment. This is all new to the medically assisted treatment world because we have people now trying to deal with the stigma associated with medically assisted treatment. And Dave can speak to that, and everybody on the panel can speak to that. So just having these panels right here are new. Medically assisted treatment was the only treatment that when people walked in, they would tell you when they would get off. They would tell you, somebody would walk in the clinic, they would say, I'm going to be off in 6 months. It was the only treatment that people told you coming in how long they were going to do their own treatment. Now research and data is starting to go to saying it's like diabetes medication. Would you tell a client to get off of insulin? Would you tell a client to get off any other medication? So the evolution of information, like that's why we talk about the education of people, educating people, let them know now people don't have to come off this medication. But back when I was utilizing medications, you had to get off. It was told when to get off because your success was based on you getting off. It wasn't based on how long you stayed on. Success in this world was based on getting off. So I would meet people in the street and they would say, I say, how you doing? And they say, Dre, I'm detoxing. And I would say, why? Man, I said, don't try to follow me. Don't try to do what I did. I came from a different time and place. Nowadays, they're not telling people to get off or detox because it's not, statistically, we show that the outcome numbers don't support that. So talking to a family member that would say, and also this going back to the street, most of the time when people buying buprenorphine on the street because they think they know how to detox themselves. They're not trying to get high. They're trying to, they're trying to detox themselves. They're trying to regulate something that can't be regulated. And then eventually they'll walk into a program and they'll see Boston, they'll walk in the bar in Boston, they'll walk into Dave and Kensington. But when they first start off, they think they can go to the street, buy a couple buprenorphines, and they're gonna kick the thing. But they'll realize that doesn't work. But that's when we see that in the street. It's not really for people to get high. They think they can regulate their own detox right now.
And I will say this: I think there's an evolution that we've all gone through. Like, I'll speak for myself. Like, the same way that I evolved into understanding the need for medication, my experience has evolved since then as well. Like, I'm beginning to realize a lot of, like, some of the things that Andre just spoke about, that, like, we're in a new phase. Like, everything is changing, right? So, like, I think somewhere in the chat, I think I saw somebody asking about, like, treatment programs that are, like, really restrictive. So I think a lot of it is changing our relationships. So, like, the reality is there are people that Suboxone doesn't work for. So now methadone clinics should be partnering with these private Suboxone providers to be able, so that they can pass these clients off. Like, here's a modality of treatment that would work for you. Same thing with Vivitrol, folks. You know, and I do think a lot of it is like, you just get to know, like, hey, all right, there's a certain kind of person you may know, you may be able to identify, like, this guy may not do good with a really intense program that's like super high maintenance, bringing your pills in to be counted. So you're going to refer him to a program that's a little bit, you know, on the low end around, you know, and you kind of try to steer people in that way. I know there's a medication that's in the last stages of being approved. I believe there's some folks on this call that are involved in a study with it called Brixadi. That's the next wave of this. That's an injectable version of buprenorphine that's going to be used for induction. Like, that's a game changer, you know? So that, like, there's so many different parts of this. I think it's an ongoing discussion we all need to be having, and collaborate. And I think it was really cool with putting this together, where we had somebody from the medical field and folks coming from lived experience, and folks that have lived experience and also work in the treatment community. We can put all those eggs together to try to figure out, like, what this is going to look like moving forward. Because there's a bigger stigma issue. I think we all need to be aware of that. I won't speak for anyone else on the panel. I want to make myself as available as possible to, like, newer CRSs, because I do think having that conversation, like, understanding it, nobody's belittling your own recovery experience. Like, look, as I hear on this panel, my recovery experience is just as valid to me today as it was 17 and a half years ago.
Yeah.
But it also is not any less valid to the person that I'm helping this morning get on Suboxone, get on methadone.
Yes.
You know, whatever. So I'm sorry for the tangent.
No, somebody's agreeing with you, Dave,
I love it.
out there. Yeah. There was a really good question about restrictive treatment policy surrounding MAT, and we're at time, so I'll just answer really quickly. Like, it's very individual based, and you find out what's going to be best for the patient. Do they want IOP? Do they want a level of care, or would they do better in a low barrier, like Prevention Point, mobile buprenorphine that Maggie does, shout out, or like whatever is going to be sustainable for them. That is where we try to them to make it realistic for their recovery. But thank you all for joining. Thank you to the panel. You're amazing, and we will talk soon.
Thanks, everyone.
Thank you.
Thank you.